All right, everyone, it's just a couple of minutes past 4, so why don't we get started? Jacob Kirsch, past president of NASCI. Thank you all for joining. I see some names that I recognize in the group, so welcome everyone. I have a few cases that I prepared to show, but as hopefully you know by now, this is an open forum. Everybody is welcome to show cases, to share some of their experience or ask questions. So if there's anybody in the group that would like to start, we can do that. Any takers out there? Or you can send a note in the using the chat option if you're setting up or getting ready, so I can start with some of the cases that I prepared, and then definitely have you guys share the screen. So why don't we go ahead and do that? Let's see. So these are just a couple of cases here that I think that are worth sharing. Let's start with this one. And this is the CT of the chest. I don't know if anybody sees any abnormality here. And again, feel free to participate. Going down all the way to the upper abdomen. So any thoughts? Anybody wants to try this out?
It's missing the left major pectoralis, keeping with pollen syndrome in part.
They're very atrophic, but I think it's there.
Okay.
They're symmetrically atrophic, and again, it's a female patient, so you see the left breast is kind of hanging to the side more than the right, so that's why it gives that asymmetric appearance. That's a good thought.
There is a big mass on the right posterior chest wall, a soft tissue lesion, and I think also in the right ventricle there is a well circumcised another lesion in the right ventricle.
Yeah, good pickups, and of course this is a cardiac imaging webinar, so I better show something that's in the heart. But you're absolutely right. You made some good observations. So the first one is here in the dorsal wall. That was the reason the patient showed up initially, not for this scan. This actually, of course, grew, but there's this large mass involving the dorsal right chest, and this turned out to be a sarcoma. I don't remember the exactly cell type. And then, of course, as you mentioned as well, patient presented with this large intracavitary mass in the right ventricle that turned out to be a metastatic lesion. So I guess just as a quick, it's just a nice show and tell. It's a good images as a nice reminder. The most common malignant mass in the heart is going to be theoretically a MET. Of course, you have to have a primary to start considering a MET in the heart. The literature quotes that METs or cardiac masses and METs are about 20 times more common than primary cardiac tumors. I can tell you in my experience, it's not exactly like that. Having said that, that number, that 20-fold increase of METs versus primary, it comes from the pathology literature where they actually get to see really, really tiny metastatic implants in autopsies. So they quote a lot about melanoma as going the tumor that goes most often to the heart. But again, we don't get to see it that often in imaging. It's very common to see it in pathology and with special stains, but not necessarily that common in imaging. And I know we have some people with experience as well in the group. I don't know, Joan, Phil, would you agree with that? I think that's really relates to pathology literature and autopsy rather than what we see in imaging.
mute here. I think that's true. I also think maybe the game is changing a bit as the scanners have gotten better, and we can see the cardiac chambers and detail in them on routine scans better, that we're picking up more intracardiac metastases than we used to pick up.
Correct. That may be very true as well. All right. So again, this was just a quick show and tell. I don't even remember if there were lung mets. Let's just take a quick look. I don't think there were. Nothing is really jumping at me here. Oh, there you go.
Hey, Jacoba, can you go back to the aortic valve real quick on this case?
Of course not.
Just something just caught my eye, and I just wanted to
Aortic valve?
again, see if there's. Yeah, aortic valve. Nah, never mind. I was looking at that where the RCA was coming off too. Well, we were looking at these, but I think it's still coming off the right. Okay.
Yeah. Oh, you mean this? Yes, I think it's all motion artifact. All right, very good. Let's see.
One quick thing.
Sir.
This is Phil Young. I was going to say Phil Young here. I totally agree with Joan's comments, and I think in our practice we're seeing more often that the oncologists are more and more aware of the potential role of CT here. So instead of getting an echo or an MRI to look at the heart and then a CT to look at everything else, the chest, abdomen, and pelvis, we're doing more and more combined sort of cardiac CT that covers the chest plus ungated AP for patients who have either had a known or suspected cardiac met, who had an unequivocal echo finding, who have a thrombus at the tip of a central venous catheter, or something along those lines. It's just, if they're going to have to get a CT anyway, just do the cardiac CT as part of the comprehensive workup.
That's a good idea, actually. Definitely, especially if there's a high suspicion that there may be, or if it's one of those tumors that we know tend to go to the heart, like lung, breast, and melanoma.
When you do that, Phil, are you doing it with the same timing you would do for coronary arteries, or are you going a little later as more of a delay to get better enhancement in the myocardium to differentiate between that and the lesions?
That's a great question. At Mayo Clinic, we tend not to believe that radiation's an issue. So we actually time it like a coronary CTA, and then I usually do the AP and then do it as quick as possible, a gated delay just to the heart with dual energy. And that allows you to get kind of a late enhancement look. And particularly if it's something like a thrombus in the right atrium, the fact that on the late, you have dual energy in the late imaging and there's no uptake in the thrombus, for example, or on a valve, then it makes you a lot more confident. Or, if it's a hypervascular tumor, it often washes out like a renal cell. So that's how we tend to do it.
Mm-hmm. Okay. Yeah, and I think in general, one of the things we try to point out with our residents all the time is that for years, the heart was in the WNL category of we never looked. And now that the scanners are so good, you can't use that as an excuse. So on every oncology case, particularly the ones that are done with contrast, you need to really scrutinize the cardiac chambers, the myocardium, and the valves, in addition to the pericardium. And the other thing you want to keep in mind on the oncology patients is just as they're on therapy, they can develop cardiomyopathy. So keep an eye on the cardiac size too.
Yeah, actually, I had a patient last week who was ordered for a CT chest, abdomen, pelvis. I was on just abdomen pelvis line, and had a history of a prior myxoid sarcoma resected from the left ventricle. I know this is crazy. They're going to get an echo to look at the heart, in a kind of limited view, and then I'm going to do an ungated CT of the chest. So we did a gated CTA of the chest and a standard abdomen pelvis. And it turns out that, I was able to measure his ejection fraction. It had gradually dropped from 60 to 30%. He was a young guy who was on doxorubicin. So they canceled his last dose, and they would never have known, actually, because his next echo wasn't scheduled for 2 more months. So we can have a huge role in impacting these patients.
Mm-hmm.
I 100% agree. This new field of cardio-oncology, as it continues to grow, I think, especially, you just mentioned an example of using CT, but I think MR is potentially going to play a huge role in this new, it's not new, but it's definitely getting a lot more traction and attention in the world of cardiology. All right, let's look at this this case, I mean, I think the finding is not necessarily subtle, and I don't know how to make this go any slower. Let me just do it by hand, I guess. So anybody wants to comment on some of the findings? Again, this is a steady state free precession in the 4-chamber view, and there's a couple of things that I think are worth mentioning. And I'm going to stop right there. All right, so let me go over it. So the most obvious finding here, there's this large mass just adjacent to the left AV groove here, somewhat iso intense to myocardium, maybe a little bit brighter, but just very subtle. There's another interesting finding. There's a large right atrium, and then here we see there's definitely evidence of tricuspid insufficiency. So we have tricuspid insufficiency that there doesn't seem to be mitral disease, even though this mass is, if anything, putting some mass effect upon the posterior mitral leaflet. So keep those things in mind. Let's see now. I want to show you something else.
Can I ask something? Is there anything in the interventricular septum towards the apex, especially on the RV side? Thing you are showing.
Yeah, that may very well be. It has that also slightly difference in signal intensity that's a very good pickup, when I narrow the window a little bit more.
Wow, good eyes.
Good eyes.
And the RV is not dilated despite the tricuspid regurg, right? It looks
fine in this view, yeah. Let's see. Where are my long axis views? Let's see, maybe this one. Oh, yeah. So this is just a slab of, you can see that the RV is not necessarily large. And you're right, it seems like there may be a little bit of a mass there. Big right atrium. And now as we go up, let's see if I can convince you here on this one. This is where the pulmonic valve is, and there's also a jet of insufficiency. So there seems to be some component of pulmonary valve insufficiency as well, not just tricuspid. So we have a couple of masses here in the heart, but just as important, we have right-sided valve disease. So I think those are good clues. And look at while you guys think about it, let's look at the enhanced images. So this is short axis. There may be something here, which is what we were looking at on that 4-chamber view. And of course, this big mass here towards the base of the heart near the AV groove. And there's other findings here. There's actually another big finding here. Anybody wants to comment on that? I'll lift my cursor right on top of it.
Yeah, there's a big mass in the liver as well.
Yeah, exactly. Big hepatic masses. There's another one here.
Yeah, and multiple. Yeah.
Yeah. All right. So when we put everything together, anybody wants to shout out what they think?
Carcinoid.
Yeah. So patient also. Yep. Okay. So let's see. I need to close this if I want to show you part of the CT. So the patient has a CT images. And there's way too many images here, so let's just select a few. So you are right, this is a case of a carcinoid tumor. Let's see, come on, viewer. Why is this not letting me open? All right, here we go. Okay. So here we see again that mass, lateral wall of the left ventricle. The really great pickup here towards the apex of the heart. And then we just see this large hepatic. I didn't go down enough, but never mind. I mean, you do see all this. So this metastatic carcinoid, again, once you have enough involvement of the liver, that's when the excreted serotonin doesn't get metabolized fully, and that's why you start having right-sided cardiac valve disease on these patients. So you must have some hepatic disease or significant hepatic disease before you start seeing valve issues as well. So another nice show and tell here.
That's a gorgeous case.
Thank you. More than happy to share the DICOMs if you want them. All right, so those are the cases that I had in DICOM format. Then I put together just some selected images from a couple other cases. Let me put this in play mode. All right, here we go. So this is a pretty straightforward, just severe, extensive hypertrophic obstructive cardiomyopathy. You can see the severely thickened left ventricular myocardium, and then you have a lot of the other findings that go with it. You have the outflow tract obstruction with high velocity turbulence, and that's all that signal loss going out starts below the level of the valve. It starts really at the LVOT. You have the systolic anterior motion of the anterior mitral leaflet, and you can see it here during systole when it should be closing. It's actually moving due to that high velocity. It's getting pulled towards the septum, and that also creates that the mitral leaflets don't come together as well, and so that's why you get this mitral insufficiency jet. Again, usually the jet goes in the opposite direction of the leaflet that's being affected. So this is the anterior mitral leaflet. So then the jet is posterior. It's directed posteriorly. That's a good rule of thumb to when you want to try to guess where the abnormal leaflet is on any given case. This patient went for failed medical therapy, and he went for surgical therapy, which is septal myectomy. Basically, the way that they do this, they come from above the sternum, they do a small aortotomy, and they then introduce the scalpel, and kind of almost blindly, because I don't think they get a really good view of the surgical field. They just start scraping where they know the base of the septum is going to be, and they just start cutting at it and trying to open up the left ventricular outflow tract. Again, the field of view is very limited, and they have to put the scalpel through the aortic valve level, which of course puts at risk the valve leaflets. This is in that particular case. That's how much little pieces of myocardium they were able to take. That's a bit significant. And this is the post-op case, and you can see this is the same patient just a little bit after surgery. You can see that there's a significant relief of that obstruction at the level of the outflow tract. By mid-ventricle, you're still going to have some obstruction just because of how thick that myocardium is. So you see that still there is some high velocity at that mid-ventricular level. But this significantly improved this. It significantly improved or probably resolved the mitral insufficiency that was associated with that SAM. So a very nice result of septal myectomy on this patient with extensive hypertrophic cardiomyopathy. Now, the other option that these patients have when they fail medical therapy, well, before I go to that, let's look at this one. This is a different patient. He also underwent septal myectomy. Is there anything here that bothers anyone? It's an extremely subtle finding. So this patient developed, let's see if I can. If I can convince you guys. This was initially mentioned on echo, and it was part of why the exam was done. There is some So I'm taking here an stair-step artifact of the aortic valve leaflet. When they came in for the aortotomy approach, so again, the scalpel coming down and through the valve orifice, they damaged the valve, they cut through it, so they had to go in and sew it back together. And that's why it got a little bit tethered and has that stair-step rather than being just one straight leaflet. So they damaged the aortic valve in this patient. So this was just for further assessment. So again, this is one of the complications. It's a nice example. It's very subtle, and you have to really, I guess, know a little bit about it and specifically be looking for it in order to catch it. Okay, so the other therapy that's being proposed for patients with hypertrophic cardiomyopathy that failed medical therapy is the alcohol ablation. So septal alcohol ablation, and this is an actual case. You can see they're doing this an LED angiography. Then they did a super selective catheterization of the first septal perforator. Again, so this is the LED. The way to recognize the LED for those of us who are not cardiologists, this is ways when you see all these straight branches just going down, pointing at the feet of the patient, you know that's the LED. Those are all the anterior septal perforators. So this is the LED, and they picked and selectively catheterized the first septal perforator, and then where is that picture? There's a little balloon there that they inflated. You can see there, and then they injected. This is disinflated to avoid that the alcohol doesn't reflux into the rest of the heart. Then they injected alcohol mixed with a little bit of contrast just to see where it was going, and they basically injected the alcohol into that septal perforator, giving the patient a controlled myocardial infarct, right? This is, I'm assuming, and I've heard, supposed to be extremely painful, so the patient is under anesthesia for this. It's like having a really bad heart attack. So that's what they did in this patient. And this is what the post-therapy images look like. You can see here on the 4-chamber view, there's late gadolinium enhancement in that basal part of the interventricular septum. Again, this is not the coronary distribution that you would expect in an LED infarct. This is super selected to that first perforator. And you can see it here on the short axis. And you can see that centrally, it's extremely dark. That's a microvascular obstruction. That's complete myocardial death centrally in that area of infarct. So this is a case of hypertrophic cardiomyopathy that failed medical therapy that had to be treated with a procedure. So just quickly, I just prepared this. This is a very nice meta-analysis that was published just a few months ago in the Journal of Clinical Medicine. It's a meta-analysis comparing the literature on septal ablation with alcohol against septal myectomy treatment. So I just selected a few points that I thought were interesting to share with the team. Again, as we know, significant left ventricular outflow tract obstruction associated not just with symptoms, but also with risk for all-cause mortality, cardiovascular complications, sudden cardiac death, etc. To control symptoms, patients are, of course, first tried to go through medical therapy, but when they fail, the two most common therapy options are going to be septal myectomy and alcohol septal ablation. Septal myectomy, considered the gold standard, has been done for a longer period of time. Having said that, alcohol septal ablation is now gaining a lot of traction, especially in patients who are poor candidates for surgery or are high risk for one reason or another, or simply they don't want to have anybody open their chest for them, and it's been gaining some traction. So these are some of the points of the meta-analysis. So again, the septal ablation patients were slightly older, as expected. They're not as good candidates for surgery potentially. The gender ratio was about the same. And again, the LV size and structure were about the same for both groups in this meta-analysis. They had similar short and long-term risk for all-cause mortality. Interestingly, well, as expected, I guess, alcohol septal ablation associated with a lower risk of peri-procedural complications. So, of course, a catheter-based procedure is going to have less complications in the immediate peri-procedural time than open heart surgery. Having said that, they did have to have more re-interventions if the symptoms were not relieved. and as well more pacemaker implantations compared to septal myectomy. At follow-up, septal myectomy patients had greater reduction in the gradient across the left ventricular outflow tract and great improvement of the clinical symptoms compared to alcohol septal ablation. What else is important here? There's just a little bit of the same, and I have the reference there at the bottom as well for anybody who's interested. Again, it's a nice review of the literature with that meta-analysis of all the data of those papers, and they had a very nice graph here which summarizes everything. So everything that has a little red square, that means that it's statistically significant. The little blue dot, there was no statistical significance to those findings. And again, the better outcome is on which side of that vertical line this lies. So basically summarizes what I just said on the prior slides. All right, so just wanted to put together a few cases with a common theme for you guys to have a bit of a discussion. Any comments, anything that you guys want to add to that? Okay. Any of you have any cases to share? That's what I have to prepare for today. So if anybody has cases, I can make you presenters now. I see Carol unmute
I have a
herself.
couple.
Fantastic.
Yeah.
Thank you, Carol.
Just waiting for
How are you?
others. Come on, guys.
Let's see. I'm gonna make you presenter
Yeah.
now, and you're gonna accept that. Did you get the request?
Yeah.
Perfect. All right, we can see your screen.
Okay. So I put these together really quickly today, so it's not very not as impressive as your cases, Jacobo, but let's see.
I stole them from you. You just don't remember.
A 39-year-old woman who presents with a STEMI. And I'll just show you the images, and then if anyone wants to speak up, please go ahead and tell me what you're seeing. So anyone want to comment? I can show you some coronal and sagittal reformats.
Hey, Carol. Prachi here.
Hey, hi,
Hey, wondering
Prachi.
about, hey, how are you? Nice case. Was wondering about spontaneous coronary artery dissection here.
Yeah, that's a really good thought. Anything pointing towards that? Like, how did you deduce that? Because that's what it is.
I saw that just given the very smoothly defined area that wasn't enhancing in, I saw it in the RCA and probably in the LAD too. And then the demographics. I thought I'm kind of reading cases in between, but I thought you mentioned a middle-aged woman or something.
Yeah, she's 39.
Yeah.
And so, yeah, and this is like, it starts in the left main here. We can see like an eccentric soft plaque. It's all on one side of the vessel, and it's very, very long. So that's one of the characteristics of SCAD, is usually longer than a plaque that causes a stenosis, and in a young age group. And yeah, it looks like there must be a smaller lesion in the right coronary too. I just have one last reformat here, curved reformat of that. You can see how long it is from the left main all the way down to D2, I think that is there. So
the prettiest
yeah.
example of that I've ever seen.
Oh yeah, so this is
nice.
this is an intramural hematoma actually, and I've been putting together a talk with SCADs, and I found, like, I looked at our PAC system, and I found 272 since 2015. So that's why I downloaded a few cases. This was a really pretty one. And it's amazing. I mean, SCAD occurs, the overwhelming majority are women, usually younger than those that present with a typical coronary artery disease, STEMI. And usually the remainder of the coronary arteries are normal, although a SCAD can occur in multiple vessel locations. There's a very high association with fibromuscular hyperplasia or dysplasia. So usually we image these patients' head and neck vessels, as well as the abdominal aorta and renal arteries, to look to rule that out, and also intracranial aneurysms. It is often associated with stress, and also has a high incidence peripartum, so can be pregnancy related. If it does occur in men, it tends to be more related to strenuous physical activity, especially weightlifting, as opposed to running or activities that, what am I trying to think of? Aerobic activities.
Yeah, resistance as opposed to
that's it.
Cardiovascular. Yep.
Exactly. So I have another case that is also somewhat similar, but very, this unfortunate woman who had, is only 23, had myotonic dystrophy, type 1. She had a normal echo prior to becoming pregnant, but about 4 weeks prior to delivery, she presented with increasing shortness of breath on exertion, and had a repeat echo that revealed what was felt to be a pregnancy-related cardiomyopathy with an EF of about 30%. And unfortunately, 4 weeks postpartum, she presented with a STEMI and had a coronary angiogram that revealed SCAD in multiple coronary territories. So I just have a few examples from an MR that was done, just to show at this time her EF was down to around 19–20%. And there's really a global hypokinesia, there's a small pericardial effusion, and I don't know if I can convince you that maybe the inferior wall is a bit even more hypokinetic or almost akinetic as compared to the rest of the left ventricle. And then delayed GAD, she has some mid-myocardial enhancement in keeping with a dilated cardiomyopathy. But she also has evidence of almost transmural enhancement in the inferior wall. So here, just a nice picture of how MR can help and is in fact able to differentiate and pick out the ischemic component and the dilated cardiomyopathy component. this unfortunate woman subsequently succumbed to her cardiomyopathy. She came in, she was managed medically, had an ICD put in, and then came in to the ED with shock. They tried to resuscitate her. She was put on, she had an LVAD put in, and anyway, she eventually succumbed to the cardiomyopathy, unfortunately. So just a very, very unfortunate case. And those are my 2 SCAD cases for today.
Fantastic, thank you. Great cases as usual. All right, anybody else who wants to share a case or ask a question or just?
I have.
Perfect, there you go.
I have one I can share. Those are great cases, Carol.
Thank you.
I have one, if you're able to share your screen.
Let's see, I send you the request.
Share. Is that working?
Not yet. There you go. We can see your screen.
Sure. This is just, I only have one kind of slide of an interesting thing we've been working on. We noticed many years ago, actually probably over 10 years ago, we were getting a number of transplant patients, cardiac transplant patients referred for MRI to look for myocarditis versus rejection. And there were a good subset of these patients in whom we saw this, I think, very striking pattern, where there's just this diffuse circumferential biventricular delayed enhancement and edema pattern, high T2 signal and delayed enhancement. Is that kind of coming across on the images there?
Yep.
Yes,
yeah,
sir.
and to me, it was just the most striking thing I've ever seen. And it was a fairly consistent finding. And so we were really excited to see what, try to correlate this with acute cellular, or humeral rejection patterns, or maybe something else like, lymphocytic infiltrates that they call quilty lesions. And we went back and looked at, I think at the time, 10 patients who all had good path correlation, and one who had actually gone to autopsy. And we couldn't find anything. Pathologists were like, nope, looks normal. And it's astounding to be this profound, right? And have absolutely no histopathologic correlate. And so it was extremely frustrating. And so even the autopsy patient, right, who had rejection so bad that they died of it. And so anyway, eventually, after collecting another, 10 more years of cases, we have gone back and done another analysis that we're trying to get through the literature. Had a little trouble in peer review, but essentially, they looked at, correlation with, biopsy. And again, there's very poor correlation with any sort of, rejection or myocarditis. But what is clear is that when patients have this pattern and they have a reduced EF, they all invariably have a reduced EF, usually 40% or 30% range. And when they give them immunosuppressives, it gets better. So we think this is actually probably a better marker of rejection than biopsy. And, the question of why they don't see anything at the time of autopsy or biopsy is still up for question. But you notice it's largely an epicardial process, right? Whereas the biopsies they'll obtain will largely be endocardial. And you certainly have a certain amount of sampling variability in that process. And there's also just sort of the question of the timing, right? And what happens, and if it's really edema, how well is that something that's really visible, just the water content on histopathology. So in any case, this finding, at least in our experience, has seemed to correlate with the likelihood that somebody's EF responds with immunosuppression. And then the one thing that's interesting is that the enhancement tends not to go away. It may improve, but it still persists. So it probably becomes less sensitive as a marker if a patient goes through a second or third episode of rejection. So not peer reviewed yet, but this is just kind of an interesting thing we've been going over recently. I wanted to share it to the group.
Super interesting. Phil, that T2 sequence, that's super sharp. Are all your images looking that good? All your T2 images?
They've gotten better, actually. They're better than this now. You know, I think this is just, I'm not, you know, paid by anybody. I think the GE scanners, in our experience, tend to have much better T2-weighted images than Siemens scanners in general. We've taken to, you have to be really careful with the trigger delay. So the recommended trigger delay on these vendors generally doesn't work. They've been set to try to go fast, to go, you know, quick breath holds. But it's just like cardiac CT. You have to correctly set the timing, you know, in the cardiac cycle and have it short enough that there's not too much motion there, because it's a very motion-sensitive sequence. So you have to go to a fairly short echo train, like 14 or 16, whereas the default like 26 or 28. And you have to go to a true diastolic trigger delay, either manually pick it off of the Cine Fiesta or TrueFit images, or just go to the, you know, the vendors recommended systolic or diastolic to try to get isovolemic contraction or relaxation for motion-free images. And going to 2 or 3 or 4 R to R, and our echo times around 85 or 90 milliseconds to really bring out that T2 weighting. We're also now using a deep learning denoising algorithm, which really helps with these images a lot too. This image doesn't have it, but they're actually, what we're getting now are fairly consistently better than this, I would say.
Nice, very good. That's great. Thanks for sharing. I'm gonna chat with you offline about this project. It's very interesting. All right, anybody else, guys? All right, so I'm happy to just share with you also that this webinar today marks a full year of uninterrupted monthly webinars showing these interesting cases. I want to thank everyone that comes and participates with us. I mean, we're going to continue doing them, but these are our first birthday for the NASCI Curious Cases webinar. So congrats to everyone, and thank you for being a part of this and being a part of NASCI. With that, you know, I think everybody gets a few minutes back of their day, and hope to see you guys next month. Take care. Thanks for coming.
Take care.
Thanks, Jacobo, for doing it.
Happy New Year, everyone.
Happy
New
New
Year.
Year.
Thank you. This was great. It was the first time I was attending, so we'll do it again, definitely.
Always welcome.